All right, good afternoon, everyone. My name is Dan Messina. I'm the President and CEO. I'd like to welcome everyone. We are very pleased to be presenting our monthly educational seminars, and I'm very happy to introduce a great colleague, Dr. Wilson. Dr. Wilson is our director of the Breast Center, and very, very happy to have the opportunity to give you a little bit of a background. Before I introduce officially Dr. Wilson, let me just say lots going on at the hospital. We are finally in the midst of our construction project, $130 million construction project, in the process of constructing our new emergency trauma department, as well as to follow will be the renovations of the second floor of the new emergency department. That'll be the future home of our new peri-op department and the replacement of our operating rooms. So lots happening there. In addition, we have a parking lot that's underway right now, and we will be adding 240 new parking spots to the campus, and that's expected to be completed in about 8 to 10 weeks, 8 to 12 weeks. So you'll be hearing and seeing more about that. As well, we're also going to be doing a major renovation of our mother-baby unit. So we will be moving forward with those renovations over the next several weeks. So we're very excited to have lots going on in the campus. But at the end of the day, what makes our hospital the quality institution that it is, it's people like Dr. Wilson and our fellow colleagues on the medical staff. So Dr. Wilson was a recent recruit, although recent, I say, is only about a year or so, but it seems like yesterday. Dr. Wilson graduated from Robert Wood Johnson Medical School, did her residency in surgery from St. Luke's in Manhattan. She did her laparoscopic surgical fellowship at Peachtree Surgical and Bariatric Morehouse School of Medicine in Atlanta, Georgia. Completed her breast fellowship. So Dr. Wilson is a fellowship-trained breast surgeon, and she graduated from Anne Arundel Medical Center in Annapolis. And last but not least, which is probably the most interesting part of her background, is an oncoplastic surgical preceptorship at Western General Hospital in Edinburgh, Scotland. So lots of exciting parts to Dr. Wilson's presence here at the Richmond University Medical Center. And so without further ado, I'm going to flip it back to Dr. Wilson, and thank you very much.
Well, good afternoon and happy Monday. So what I'm going to talk about today is kind of a mixed talk. So, I wanted to focus a little bit on breast cancer detection and prevention and things like that, and also give you just a snapshot of what's happening in the field of breast cancer treatment and a look at where we're going in the future. So with that being said, okay. So we've really seen a lot of advancements in multiple areas, including detection, risk reduction, individualized therapy, and surgical treatments. Oh, sorry. So, I think, first it really has to be said that what's amazing in the field of breast cancer is that we're really doing well. We're doing much better with detection, and I'm seeing many more women who are diagnosed now with early stage disease, where I can confidently say to them that, we can take care of this cancer for you and you will get on with your life. And in fact, today, less than 30% of women who are diagnosed with a breast cancer will actually die from their disease, which is really remarkable considering what the statistics used to be. So right now in the US, there are over 10 million cancer survivors. Over 2 million of those are breast cancer survivors. And we have women with breast cancer who are living, even with metastatic disease that's gone elsewhere in their body for over 20 years. So it's really important that the needs of these women are met as well. So how did we get there? Well, we got there by increasing our early detection and by our advances in medical treatment. And early detection is really the key. So here are some breast cancer statistics by stage. So for women who are diagnosed with a very early breast cancer, stage 0, what we call ductal carcinoma in situ, what's their 5-year survival rate? 100%, right? So those are women that I can confidently look in the eye and tell them, we will cure you of this breast cancer, okay? And that's why it's so important for women to get their yearly mammograms so that we can find disease at this early stage when it is in fact curable, okay? So we see that as the stages go on and women are diagnosed later, that the survival is not as good. And so again, that's why early detection, going for those annual mammograms is really key. So what is it that we should be doing? So self-breast examinations. You know, I know that a few years ago, some data came out that said, oh, self-breast exams are useless. You know, I think that study was done in a different population than we see here in the Northeast. And, you know, the truth of the matter is, I see women all the time that find their own breast cancers. They feel a lump, they come in for evaluation, okay? So I believe that self-breast exams really do still have a role. When should they be done? For women who are still menstruating, they should be done the week after their menstrual period. For women who are no longer menstruating, who have gone through menopause, you just pick a date. You know, if it's the 1st of the month when you pay your bills, the 15th of the month after you've forgotten your bills, or the end of the month when you're hoping that they won't come again, your bills, you know, just pick a time. And that's the best time to do it. So once you turn age 40, you should be having annual mammography, okay, every year at the age of 40. A lot of times people ask me, when is it safe to stop mammos? And you know, the reality is that breast cancer is typically a disease of older women. And so, you know, if you're in good enough health to get yourself to the imaging center and step up to the plate, then have your mammo. Because again, when we catch something that's small and early, it's much easier to intervene than at later stages. So as long as you can step up to the plate, I say get a mammo. I tell people when you get to be about 80, you can go every other year instead of every year. And MRIs are useful for women who are at higher risk for developing breast cancers. And so these are people who have genetic mutations that are increasing their risk, have strong family history, have had biopsies before that showed some atypical or abnormal cells, and other women where if they have very, very dense breasts, the mammography may not be as reliable. So this is an example of a digital mammogram, okay? Nowadays we have 3D mammography, and that is really the gold standard now. So if you're not going to a center that has 3D mammography, you really should consider changing your center, okay? So a mammogram, a standard mammogram, is 2 views done on each breast. And what it really allows us to see, I don't know, is this pointer working here? Oh, no, sorry. But you can see here in this breast, there's the breast cancer, okay? So mammograms are extremely useful, particularly for detecting the earliest breast cancer, which sometimes just shows up as little calcifications on the mammogram, okay? So mammograms are extremely important. This is a picture of a breast MRI. As I said before, breast MRIs are done for women who need additional screening because of their high risk status. And you can see MRI, you get an injection of dye. And so with MRI, the cancer lights up like a Christmas tree. So you could see on this MRI, here's the big area of cancer there. Okay. There are some cancers that show up better on MRI than even mammogram. So it's really important to put all the modalities together So you do your self-exam, you do your mammograms, you go see your physician like me, and then I will determine if you need additional screening or, if you've had everything that you need. So I just want to hit on this for a minute because I still get people who come into my office and they say, if we say, okay, there's a finding and you need a biopsy, and they ask the question, well, doctor, you need to take me to surgery rather than doing a needle biopsy, because if you put a needle in it, cancer spreads. Okay, so if there's anyone out here today that is still of that mindset, I want to let you know that this has been exhaustively studied on hundreds of thousands of women. Okay, and we know very confidently that with a breast cancer, you do not spread the cancer by putting a needle in it. And what's more is that there used to be a day when we didn't put needles in these and we just sent women to the operating room for a biopsy. You know what we discovered? That those women, if they had a breast cancer, they didn't survive as well. And the reason why is because they were going to the operating room and having the wrong surgery. So we really learned that it's important to know up front whether or not this is actually a breast cancer. And the way we determine that is putting a needle in the lesion, in the mass or whatever it is that we're looking at, and testing that first. And then if it is positive, then we can go on from there to do surgery. So this is the surgery that everyone used to have if you had a breast cancer. It's called the radical mastectomy. And if you were diagnosed with a breast cancer, no matter how big or small, about 20 or 30 years ago, this was the surgery that you had. And so what we've seen lately is a trend much more towards breast conservation, which is maintaining the breast tissue that's not involved with the cancer, and also just individualizing surgery for women. So this is one tool that we have. It's called a lumpectomy. So in a lumpectomy, what the goal is to remove the cancer and a rim of normal tissue. Okay? So traditionally, this is how a lumpectomy is done. So in this diagram, you can see there's a cartoon showing a large breast mass there. So what surgeons would typically do is make an incision over that mass and take out the cancer. And then at the end of that, they would just close up the skin and the woman would go on to have radiation or whatever her other therapies were. Unfortunately, in that approach, what ends up happening is what you see there. Severe scarring, defects in the breast. Women are feeling, horrible when they take their shower and when they're dressed in the day because they're feeling deformed. And these problems can be quite severe. And after radiation therapy, they can cause a lot of retraction in the breast and be very deforming and even painful. The other thing is, in the past, we've never considered if you're removing a breast cancer on one side and taking out a significant amount of breast tissue, what do you do with the other side? So we used to do nothing. And then women would end up like this, with having one large breast, one very small breast. Can you imagine how difficult it is to find a bra that fits, feel good in your clothes, find clothes that fit? So in the introduction, what was alluded to is that I have a subspecialty, which is called oncoplastic surgery. And I went to Scotland to learn these very specialized techniques. And in oncoplastic surgery, what I do is I merge together cancer surgery with plastic surgery techniques. And so the cosmetic results that I get are far superior, and I'm actually able to get better cancer results because I'm able to remove more tissue without sacrificing the cosmetic look. So what this shows in the surgery that I do, I don't make incisions right over tumors and take them out. Okay, so what I do is I make specialized incisions, kind of like this, that heal very well and allow me to take out the tissue and still leave the woman looking whole and intact. So this actually is a picture of one of my patients. She had a left breast cancer. I did a lumpectomy on her and a reduction on the other side. So this is before surgery, and that's after she's had her cancer surgery. So, the wonderful thing about these techniques are you can have your cancer surgery and actually feel good about yourself afterwards. And since I don't leave any defects in the breast after the woman has radiation, there's none of that horrible scarring and retraction and pain that you see with other surgical methods. Now, not every woman is a candidate for a lumpectomy. Some women will need to have mastectomy. Sometimes that's because the amount of disease that's in the breast is too great. Sometimes there are multiple areas throughout the breast, and so you can't get at it with one small area. There are certain entities like inflammatory breast cancer that require mastectomy. So this just shows you some examples. So here, if you see all that bright area there, that's all disease. So clearly there's no way for me to conserve this breast. She needs a mastectomy because there's just too much disease throughout. In this one, you see cancers in multiple areas of the breast. Again, I can't take holes out of different places in the breast. That's not going to work well. It's not going to have good blood flow that it needs to heal. So someone like that would also need a mastectomy. So I showed you what mastectomies used to look like 20 years ago, right? This is what a lot of mastectomies look like today. Okay, so the doctor is just making an incision across, removing the breast. Then it's flat. Sometimes they can have reconstruction, but this is the type of surgery that's typically performed for mastectomy. So I do my mastectomies a little differently. So I can do what's called skin sparing techniques and also nipple sparing techniques. So this is a picture of a patient who's had a skin sparing mastectomy. So on this side, her nipple areolar complex was removed and the rest of the breast tissue was kind of cored out, kind of like if you take an orange out of the peel. And then she had reconstruction with an implant, and then the plastic surgeon did a tattoo and created a new nipple for her. This is a picture of one of my patients who had bilateral, that means both sides, nipple sparing mastectomies. So this is her, the top is her preoperatively, and the bottom, you see, that's 1 week after surgery, after I've removed both breasts, and she had implants placed in for reconstruction. You may notice that she's a little bigger post-operatively. She chose to be so. But I think the beautiful thing is that even after mastectomy, a woman can feel whole, can feel complete. This is another patient of mine who had bilateral nipple sparing mastectomies. This is her preoperatively. That is postoperatively after I've removed both breasts and she's had reconstruction with bilateral implants. We've seen a lot of advances in reconstruction as well. So, we do still sometimes use silicone implants, but the silicone implants that are used today are like gummy bears. So even if you cut them in half, you get two halves and you don't have the liquid that used to leak out and create havoc. We also have a lot more opportunities to move tissue from one place to another. They can use the belly tissue, they can remove tissue from the back, they can even use tissue from the thighs and buttocks to sort of rearrange and create new breast. So this is an example of that. A woman who's had a nipple sparing mastectomy and the tissue from her abdomen has been used to create a new breast reconstruction for her. So, we talked about detection, we talked about some of the medical advancements, and we also need to talk about risk reduction. Okay, so a couple of things to really remember is maintaining a healthy weight. Okay, for women who are obese, then there's more estrogen circulating, and more estrogen actually increases the risk of breast cancer. Okay, so maintaining a healthy weight is important, avoiding smoking, alcohol only in moderation, regular exercise. And what does that mean? Well, they've actually studied what that means, and that means at least 45 minutes, 3 times a week. And decreasing estrogen exposure. I throw that in also because it's very important to note that women who are taking hormone replacement after menopause are in fact increasing the risk of developing breast cancer. Okay, so what I always say, you know, some people absolutely need something to help them get through their days and work and things like that. You need to talk to your doctor, make sure you're on the lowest possible dose, and make sure that there's an exit strategy for it. So I get people in the office who have been on hormone replacement therapy for 30 years. That should never happen. Okay, there should be a start time and say, okay, well, over the course of a year or two, we're going to plan to decrease the dosage and get you off of it. Okay, family history, you know, we can't do anything about our family history, but it's very important to know our family history, because there are certain genes that run in families that actually increase your risk of breast cancer and other cancers. So part of what I do when someone comes to see me is I ask them about their family history, and I use that as a way to determine how high their risk is of developing breast cancer. And then I can even do testing of their genetics, which I do in the office, and we will look into their DNA makeup and see if there is a mutation in their DNA which is increasing their risk. Okay, but it's very important to know these things. So my office is at 1161 Victory. That's where I have my offices. I see patients, I see new patients, I see established patients. I have a nurse navigator who's here. Wave, Arlene. So Arlene is actually in my office, and for women who are diagnosed with breast cancer, you know, she really becomes their best friend. So she takes them by the hand. She helps them to set up appointments that they need, to make sure they get to treatments that they need, really facilitating, giving, you know, emotional support when required, and really making sure that we do everything that we can to make the path towards navigating breast cancer easier for the patients. And she's my right-hand woman, so thank you so much. I couldn't do without her. Thank you, Arlene. And which brings me to another point. The team that I have in my office is absolutely amazing. Okay, they are a team of dedicated professionals who really understand that women coming to us are in a state of crisis and fear, and we are dedicated to meeting everyone who walks through the door with compassion, with kindness, with understanding. And we are there to help, and that is our mission. So my team at the office is incredible. I do consultations. I also do high-risk screening. So for people who just have a strong family history and want to come to me and say, okay, well, what is my actual risk? Do I need to be doing anything differently in terms of my imaging? I meet with them. I have a full consultation. I'll do the genetic testing if necessary. We'll discuss the results and set up a plan for them going forward. Okay. Right attached to my office is the breast imaging services, and they have 3D mammography and ultrasound, and biopsies are done there as well. And you see the number below if you would like to call or need to set up an appointment. And that's all I have today, and I thank you so much for being here, and I'd love to entertain any questions. Thank you. Okay, you and then you.
Thank you very much for inviting me to talk. You showed us the DCIS survival rate is 100%.
Yep.
On the other hand, the mortality rate for non-treated DCIS follow-up 5, 15, 20 years is 3%.
Mm-hmm.
So
That's not from DCIS, though. That's from the subset of DCIS that if DCIS is untreated, it will convert to invasive breast cancer. The mortality comes from invasive breast cancer, not from DCIS. DCIS is confined to the breast. It has not developed the ability to travel, so it cannot affect your mortality.
So in other words, so in that case, if that cannot metastasize, should be treated or not?
I'm sorry, what?
If the cancer cells in DCIS cannot be spread over, so should it be treated or not?
Okay, so so what he's asking is, if DCIS is confined to the breast and it can't spread and there's no risk to your health, can it be untreated? And the reality is that there is a subset of DCIS that can be untreated. There's a subset of DCIS that if you did nothing, nothing would happen. It would just stay in the breast for years, and in some cases even regress in the breast. Okay. The problem that is, as of today, we cannot confidently identify those cases. They're working on it, and there are current research protocols in place that are trying to sort out those DCIS forms that can be just left alone as opposed to those that need to be treated. But since as of today, we can't confidently say, okay, this is a DCIS that we don't have to worry about versus this is a DCIS that could progress to invasive breast cancer, we treat them all the same. And that will be evolving and changing as the literature and data proves out, but we're not there yet.
Thank you.
Okay.
Yes, I have a question. I have a needle biopsy done many years ago. My doctor was a professor in Monson High. He told me that the liquid was white, that I don't have to worry about it, but that I do have fibrocystic breast. Okay. Now my concern is that every time I have mammography, it's very, very painful. If I have the sonogram, can detect as well as mammography, or you must have both done?
Okay, so first let me say, I cannot give anyone specific and individual medical advice today because there are a lot of factors that go into this and I'm not privy to all. Okay, so since I can't review everything to render a medical opinion, I will not render individual medical opinions today. But what I will say is, so you had two questions in there, I believe. Your first question was, mammography is painful, can I substitute that with ultrasound? Okay, so the answer to that is no. Remember when I discussed that mammogram is what finds those tiny calcifications, which often indicates early stage disease when we want to catch it, okay? By the time something is able to be detected on ultrasound, it's too late. You're probably already at a stage 1 at least, okay? So really the gold standard for detecting early breast cancer is mammography. For women who have a lot of discomfort during mammography, if it's okay with your medical doctor, what I usually say is, take 400 to 600 milligrams of Advil about an hour beforehand. That will cut down on some of the inflammation and might make it a little more comfortable for you.
There is another substitution. I'm allergic to Aleve. I cannot take those.
Tylenol.
Tylenol.
Yeah.
Oh, okay.
Okay.
Okay. Thank you, doctor.
You're so welcome. Oh, and the other thing I want to say is when you were talking about your aspiration, which is what it sounds like you had, there are times if cysts are fluid-filled sacs in the breast. They're very common, particularly in people who have fibrocystic changes in the breast. And those are not malignant. They don't turn into cancer or anything like that. So often if I see someone and it's very clear that they just have a cyst, I withdraw the fluid, I discard the fluid, and they go on with their life. Okay, so you had a question?
Is the mammography sufficient for women who have implants? Do they need something else?
No, so mammography is sufficient for women who have implants. They have specialized techniques where they actually pull the breast tissue off the implant so that they can visualize it completely. But we've been doing this a long time, and so if you're in a good center, they should have no problem with doing mammography with implants in place.
Hi, I see your presentation and I want to congratulate you. You do a good job
Thank you.
and it really was the interest, whatever I see, whatever you say. But I have one question. People who are on Synthroid or any other medication, is affect to the breast cancer, like it can get breast cancer, somebody say that?
So, as far as I know, there's no association with a medication like Synthroid and breast cancer. Again, really the medications that increase or affect risk are things that are hormonal in nature. And when I say hormonal, I mean affecting estrogen, progesterone, sometimes testosterone, because it has an antagonistic effect on estrogen. So really, it's the hormonal medications that might be an issue. And so if you have any questions about your medications, I'd say sit down with your primary doctor and say, doctor, I'm a little concerned about my risk. What do I need to be concerned about with any of these medications that I'm on?
Thank you.
For the nipple-sparing mastectomy, besides for aesthetic reason or self-image in terms of body integrity, for non-breastfeeding women, what's the major purpose to save the nerve ending?
Okay. So that's an excellent question. He's asking with the nipple-sparing mastectomies, other than cosmetic, is there any benefit to the procedure? The answer is no. So it is equivalent to a regular mastectomy in terms of cancer reduction. There's no benefit other than a cosmetic benefit.
But if nipples are removed, then the nerve endings would be removed.
No, so basically, if you remember, when I talked about doing a mastectomy, I talked about sort of like shelling the orange out from the peel, and then I pluck out the orange and the peel is left. Once I do that, once I disrupt that breast tissue from the subcutaneous tissue and the skin, those nerve endings are disrupted. So women who've had a regular mastectomy, they report decreased sensation. Women who've had nipple-sparing mastectomies likewise have decreased sensation. And the nipples that are there, they are cosmetic, but they're not functional. So they no longer get erect when it's cold outside or anything like that. They're no longer sensate like that anymore.
So in other words, even nipples are saved, but nerves are damaged.
Right. Yeah, it's a purely cosmetic approach.
There's no way to save the.
No, because you disrupt the nerves when you're going through and removing the breast tissue. There's no way to preserve those nerves.
I've heard some research surgery, microsurgery to serve the nerves.
Not for sensory nerves. You're talking about motor nerves, which is totally different. So, for example, if I'm doing an axillary procedure and I, knock on wood because I've never done it, never want to, but if I were to have a nerve injury in the axilla, that would be a situation for one of those motor nerves where I could potentially talk to a neurosurgeon about microvascular reconnections for the nerves, but not for sensory nerves.
Okay. The location is 1161 or 51?
1161. Yeah.
Is that the way a Dr. Chloe used to be, the gynecologist?
No, there used to be, was it CVS or Walgreens there? Walgreens.
Okay.
Yeah, on the corner of Victory and Clove.
Okay, thank you.
Yeah.
What's the difference between stage 0 and stage 1?
So stage 0 is ductal carcinoma in situ. So that's disease that's confined to the ducts and has not developed the ability to leave the ducts of the breast. Once it gets to be invasive disease, then that's considered to be stage 1. And invasive disease has the potential to travel outside the breast. Not that it has necessarily yet, but it has the potential.
Another question. If you're having a yearly mammography, now you have, I guess, a baseline for that, right? Now, How quickly can cancer travel, development travel, grow?
Okay, so I often say breast cancer is 1,001 different diseases, right? So like I said, you have cancers that stay in the breast for 10 years, never go anywhere, never metastasize, never do anything, just hang out there. I've also seen other cancers where someone had a clean mammography and exam. 6 months later, they come because they have a mass, they have a breast cancer that's in the lymph nodes. Okay, so you have breast cancers that are extremely aggressive and fast growing, and you have breast cancers that are extremely indolent and slow growing, and you have everything in between. So one of the things that we're able to do now is to actually look at the individual tumor biology. So once I do a surgery on a patient, I remove the breast cancer. What we do is we send it off for a specialized test called an oncotype. And the oncotype test actually looks at the individual tumor biology to determine if this is a cancer that would benefit from chemotherapy. Because once upon a time, everyone got chemotherapy when you were diagnosed with invasive breast cancer. But now we can actually separate out those invasive breast cancers that are more aggressive and would benefit from those who wouldn't benefit. So that's been a great advancement also.
What are the chances of a stage 0 or 1 returning, later on and at a different stage?
Yeah. So again, remember, breast cancers are 1,001 different diseases. So all of that depends. All of that depends on, when we look at breast cancers, we want to know, do they have receptors that are responsive to estrogen? And are they using estrogen to feed and grow? Are they using progesterone? Do they have, are they HER2 positive or negative? So there are so many factors that go into that. And really what has to happen is someone like me who has to sit down and take a look at all the factors and say, okay, well, given these 10 different variables, we can expect that, the recurrence rate, meaning breast cancer coming back, will be this, or that. And so it's very individual. There's no one answer to that.
What is the circumstances from finding one lesion or 2 lesions of breast cancer in a breast, and then lymph nodes? If they find something in a lymph node.
Right. So anytime I have someone who has a diagnosis of invasive breast cancer, and remember, when breast cancer is invasive, that's when it has the potential to spread. So as long as there's an invasive breast cancer, I'm going to check the lymph nodes. So first we check them with imaging. We see if there's anything abnormal on mammogram, ultrasound, and for some people on MRIs. And then when I go to surgery, very often I'm going to check a lymph node or 2 to make sure that disease hasn't spread.
You remove a lymph node,
Mm-hmm.
but your determination, you remove it and then test that.
Right. Okay. So anytime you have an invasive breast,
That could be another problem.
huh?
That could be another problem.
What do you mean?
Meaning that the cancer could be elsewhere as well.
So yes, so the way breast cancer spreads is it starts in the breast. If it's going to leave the breast, the first place it goes is to the lymph nodes underneath the arm. From the lymph nodes underneath the arm, if it's going to spread, it can go elsewhere in the body. Brain, liver, bones, lung, these are common places for breast cancer to spread. So if I have an invasive breast cancer, the first place I check is the lymph nodes. If the breast cancer hasn't hit the lymph nodes yet, then I know there's no chance of it being anywhere else. We can stop. If breast cancer has hit the lymph nodes, then we need to check the rest of the body and maybe do some other things.
You mentioned that exposure to estrogen can increase the risk of breast cancer.
Postmenopausally.
Did you also mention exposure to progesterone also increase the risk?
Mm-hmm.
Thank you.
Yeah.
What about those like bisphenol A, which can mimic estrogen?
Right.
Also increase the risk.
Yeah, so, there's been this whole field about bioidentical hormones. And, I think, the data isn't clear on them yet. And I think, it's hard to do research on those because those are kind of in the complementary medicine sector. And so the research isn't quite the same. But here's what I have to say about it. So people are taking these hormones because they're going through menopause and they're having symptoms of menopause and they want to stop those symptoms. Okay. Menopause is a natural evolution in a woman's life. Okay. It's not a disease. It's not something that needs to be treated. It's not something that needs to be fixed. Mother Nature has designed these to be protective. Right? So women go through menopause to decrease their risk of breast cancers and ovarian cancers and all these things that, once you're no longer child rearing, you don't need to have a period because you're not going to be rearing children and Mother Nature knows that if you just kept doing this estrogen, your rates of cancer would be higher. So nature has put in a protective mechanism. When we think we're smarter than Mother Nature and we start trying to tweak and design our own thing, well, you're bound to have a problem. Okay. So, the thing that I say to people is, menopause is normal. It's natural. Billions of women on the planet have gone through it and billions more will, and it's just one of those things. It's your next rite of passage and just embrace that. And don't try to treat it because it's not a problem.
What's the difference from the men cancer, breast cancer, and women? What's the difference?
So there really is no difference between male breast cancer and women breast cancer in women, other than men are much less likely to develop breast cancer because they have much less breast tissue. But 1% to 2% of the breast cancers that are diagnosed in men. And they get treated exactly the same way. So if men have a significant amount of breast tissue, I've done a lumpectomy on a man. Most men don't have a lot of breast tissue and they end up with mastectomies just because that's that's what's feasible for their anatomy. But they're treated the same way. They get surgery, they get radiation. Sometimes they even get hormone blockers if their cancers are responsive to estrogen and progesterone. If they need chemotherapy, they get chemotherapy. They get the same axillary surgery. So there basically is no difference.
You have a male with the breast cancer, or they go to, yes, everybody with the breast cancer, you, even a female or male?
Yep. No animals, though. I don't do dogs and cats.
Dr. Meanwhile, the cancer is progressing. What is the symptoms? Perhaps if somebody has it, to recognize
Right.
pain or I don't know.
Right. That's an excellent question. And breast cancers typically aren't painful. Okay. And that's why, by the time you can feel a breast cancer is usually about 2 centimeters in size. So really, that's later than you want it to be. And so that's why it's really important, I think, to do self-breast examinations because there aren't going to be any signs. By the time there are signs or symptoms, it's way too late. So you really want to be doing your annual mammogram, which can help detect disease early. You want to be doing your self-exams, like I said, once a month. So I think you're welcome. I think we have time for one more question. Anyone? All right, then I say it's been such a pleasure. Thank you so much. I'm having trouble.
I just wanted to say hello. I'm excellent. You are fantastic.
Thank you so
I worked
much.
with you on this.